And an ulcer is also defined as a crater that extends through the entire thickness of surface epithelium and involves the underlying connective tissue. So you basically have to differentiate how an ulcer looks and how it is different from an erosion, which is only a partial erosion or partial discontinuity of the covering epithelium. Now, if you look at the epithelium, you can see the epithelium and the subconnectivity tissue, and the ulcers result as a series of the illustrations given in A, B, C, and D, finally evolving into complete breach of epithelium. Since this topic is about ulcers, we'll be discussing about different lesions which are showing these patterns. Now, from white color of the mucosa, you have seen the above mucous membrane, and white color of the mucosa is due to increased thickness of the corneal layer and epithelial edema, also due to abnormal keratinization and also subepithelial superficial fibrosis. The red color of the mucosa, sometimes you might be asked during the Viva sessions that how the red color of the mucosa happens. Basically, just like the differences of keratinization or the degree of keratinization you find in white lesions, although which gives a white appearance of the mucosa. Red color of the mucosa is as a result of the atrophic epithelium, which is characterized by reduction in number of epithelial cells. And it can also be a result of loss of the superficial cell layers or increased vascularization due to proliferation of vessels. This erythema or redness may further be caused by dilatation of blood vessels and inflammation of the mucosa, reduced epithelial keratinization, and importantly, cellular proliferation, signifying a possible malignancy. Now, having said that, how the ulcer is, how the white areas are, and what the red lesions are, let us see a few examples of illustrations and how they look in the clinical picture. So you can see the illustration, and following that, you can see an increased layer of keratin deposits on the stratum corneum. Similarly, you can see the whitish deposits on the sides of the tongue. If you look at the lower picture and the illustration given, you can see that area is devoid of keratin and less in number of superficial keratinocytes. Hence, you have what you call the atrophic areas. Superficial debris or candidal deposits can present as areas of white and red areas. This is another illustration showing atrophic areas. And last, the illustration and the ulceration is given in the bottom picture, where you can see there is complete loss of epithelium and showing the underlying connective tissue. Now, when you look at the previous year's questions, numerous questions have been provided. When I compiled all, I have found long answer questions showing numerous patterns of repetition over the years, including regular year exams as well as supplementary exams. So some of the questions most of the questions actually happen to be on classification of oral ulcers, and also about discussing etiology, clinical features, and differential diagnosis and management. Overall, you can appreciate the marks distribution in classification as well as in detailed etiology. In short notes, recently there has been a question many times repeated about Behçet's syndrome, recurrent aphthous ulceration, and management of aphthous ulceration, and classification of vesiculobullous lesions and management of aphthous. Actually, the topic is ulcerative vesiculobullous lesion. Vesiculobullous lesion has been taken before, and I'll be focusing on those areas where ulcerative lesions are presented in the different questions. Now let us move on to the classification. There are many classifications of ulcers. I think you can use this exhaustive and simple classification that is given in the Burkitt textbook. So you see they have divided the ulcerations into acute, chronic, and recurrent forms. So the acute Again, they have divided into acute solitary ulcers and acute multiple ulcers, and chronic ones such as chronic solitary ulcer and chronic multiple ulcers, and recurrent forms of ulcers like solitary multiple ulcers. So we'll be looking towards traumatic ulcer. I think the second form of the acute multiple ulcers, that is herpetic gingivostomatitis, varicella zoster, and all those vesiculobullous presentations have been taken earlier on. So I'll be not moving into those areas. Then also chronic multiple ulcers represented by pemphigus vulgaris, bullous pemphigoid, etc., have been covered in vesiculobullous lesions. So I'll not be moving around those topics. And in one of the questions, I saw classify ulcers based on etiology. So in this book, Clinical Pathological Correlation by Regesi Squiba, they have given a small and simplified classification based on etiology. They have divided the ulcers into two groups, like ulcerative lesions and vesiculobullous lesions. So in ulcerative lesions, we have reactive lesions, then bacterial, fungal, and immunological diseases and neoplasms, whereas in vesiculobullous lesion, they have included viral diseases, immunological diseases, hereditary diseases. We'll be following those ulcerations which have been described in the first classification or given in the Burkitt's textbook. Now, we'll discuss about recurrent aphthous stomatitis. It is also known as canker sores, and it affects around 20% of the population worldwide. And the clinical features mostly, it happens during the second decade of the life, and most patients have 2 to 6 lesions at a time and experience several episodes in a year. And recurrent aphthous stomatitis has been classified as minor, major, and herpetiform ulcers. So we will have a quick look into the classification again. And we have discussed the question that etiology carries a lot of marks. So let us see how are the etiological factors involved in this. There has been a link between recurrent aphthous stomatitis and various microbial agents or commensal organisms in the mouth, including oral streptococci, Helicobacter pylori, varicella zoster, and cytomegalovirus, HHV6 and HHV8. There is also inclusion of local factors. Then another etiology has been focused along local immune dysfunction, mainly lymphocytotoxicity, alteration in CD4, CD8 lymphocyte ratio, especially when you come across HIV patients who have deranged CD4 and CD8 value, they forms during this time aphthous-like ulcerations in them. Then also antibody-dependent cell-mediated cytotoxicity and also dysfunction of cytokine cascade. Then there is also a role of hereditary in this etiology, where some patients also report their parents is also having similar episodes of on and off episodes of recurrent aphthous stomatitis, and genetically specific human lymphocyte antigen has been touted on that. Then whenever there is this sort of disease, always look into the hematological profile of the patient, whether it is iron, folate, vitamin B12, and ferritin levels. Then in a significant cases where the gastrointestinal system is involved, especially the celiac disease, gluten intolerance, individuals also show this sort of ulcerations in mouth. There are some syndromes associated with recurrent episodes of aphthous stomatitis. One of them is your PFA syndrome. It is a periodic fever, where the patient experiences periodic fever, aphthosis, and pharyngitis with regional adenopathy. There is also another syndrome, which I forgot to mention, that is your MAGIC syndrome, mouth and genital ulcers with inflamed cartilage. That will be taken into a different context, especially when we are discussing its systemic involvement and having systemic vasculitis. Then smoking, an etiologic factor, has also been said about here. Studies showing that this recurrent aphthous stomatitis is actually less prevalent among smokers when compared to that. But that doesn't mean smoking is also included for, or telling that it offers some protection from recurrent aphthous stomatitis, because it is that inflammatory reactions are stepped down by these nicotine substitutes. Anxiety, several bouts of depression, anxiety, periods of psychological stress can activate recurrent aphthous stomatitis. Menstruation, upper respiratory tract infections, and food allergies are also considered in the etiology and pathogenesis of recurrent aphthous stomatitis. Just as we classified subclassified the recurrent aphthous stomatitis, we have minor ulcers, major ulcers, and herpetiform ulcers. As you can see in the picture, minor aphthous ulcers accumulate to around 80% of the recurrent aphthous stomatitis cases. These are ulcers generally less than 1 centimeter round and in non-keratinized mucosa involving only superficial epithelium. Usually you can see 1 to 4 ulcers. These ulcers, they heal within 1 week, and the process is complete in 10 to 14 days, and these heal without scar formation. Then major aphthy, which is also called Sutton's disease. Here the ulcers are larger than 1 centimeter in diameter and affecting non-keratinized mucosa as well. But these last for weeks, if not months. And usually you can see 1 ulcer and sometimes deeper ulcer coalesce to form larger areas, extremely painful and interfere with speech and eating. Most of the time, these major ulcers heal with a scar. Least common type of recurrent aphthous ulcer is the punctate type or herpetiform ulcers. Is usually less than 5 millimeters in diameter and appears as recurrent crops of dozens of ulcers throughout the mucosa. And usually at one time you can see more than 10 punctate ulcers. So the clinical features, there will be always prodromal burning sensation before actually an ulcer appear. By now the localized area of erythema forms, and within hours papule is formed, and that ulcerates, which gradually enlarges over 48 to 72 hours. And these are symmetrically round and shallow, just like a viral ulcer, and they don't have tissue tags. And tissue tags, you can use them for in your differential diagnosis, because most of the time tissue tags are present when a vesiculobullous lesion rupture and leaves the tissue like that. In these ulcers, you don't find tissue tags. And buccal labial mucosa are more commonly involved, and keratinized mucosa like gingiva and palate are less commonly involved. And the multiple lesions, number, size, frequency also vary considerably. Lab investigations are usually not wise, but they are always obvious from clinical appearance and history. And these lab investigations are ordered when patients do not follow the usual pattern of recurrent aphthous stomatitis. Like, for example, severe episodes, like we have seen, major and minor, they have a time frame, like from weeks or maybe months. But if there is something like the age of the patient, like for example, we say that it is almost in the 2nd decade, but if the episodes of ulcer is in an older age group, or if there is severe episodes and there are signs and symptoms that do not synchronize with those of recurrent aphthous ulcers, then we can go for lab investigation. So there should be a serum iron, folate, vitamin B12 levels, as well as ferritin levels assessed. Then there is also an indication for biopsy when it is necessary to include to exclude other diseases like Crohn's disease, sarcoidosis, and pemphigus. Okay? And we have seen in the etiology, those with altered CD4, CD8 ratio have this sort of thing. So HIV infected patient, particularly those with low CD4 count, develop major aphthous ulcers. And the management is usually revert to mild cases with 2 or 3 lesions. It is usually application of a protective emollient directly over the ulcer, and pain relief can be obtained by a topical anesthetic, 2% viscous lidocaine swish and spit for around swish for around 3 to 5 minutes several times a day. In severe cases, you can have topical steroids like clobetasol, betamethasone, and fluocinolone applied 2 to 3 times daily over the lesion after meals and at bedtime. And there are also systemic therapy where used to reduce the number of ulcers like pentoxiflin, dapsone, colchicine, and thalidomide. Thalidomide, well, you know the side effects of it, like it's a potent teratogen. And for larger lesion, there is always an option for placing a gauze containing topical steroid over the ulcer for 15 to 30 minutes. And topical tetracycline mouth rinse can also be employed in case of for larger lesions. Then finally, we have intralesional steroids that are used to treat large indolent major. Always start with topical steroid before moving into systemic steroid, and finally do intralesional steroids. Then you might be wondering about the difference between the recurrent aphthous ulcer and recurrent herpetic stomatitis, which deserves a differentiation. You can see the recurrent aphthous ulcer, we have seen the wide range and also the second. And sometimes you can see the recurrent herpetic stomatitis that are more common in the middle age or older age group. The site of this recurrent aphthous more common on the mobile and non-keratinized mucosa, whereas the recurrent herpetic lesions comes and favors the vermilion border of the lips, that is the herpes labialis, and the mobile keratinized mucosa in case of recurrent herpes stomatitis, intraoral herpes stomatitis. And there is initial lesion forms as an erythematous macule, whereas the recurrent herpetic stomatitis, they begin as discrete vesicles without a halo, whereas in recurrent aphthous ulcer, we can definitely see a halo during the initial lesion. And mature lesion in case of recurrent aphthous is, like, as we said, we discussed around less than 1 centimeter, but the range is between 0.5 to 2 centimeters with a necrotic center and a red margin, whereas these recurrent herpetic lesions, they form shallow ulcers, which are actually as a result of coalescing of multiple smaller ulcers to form larger irregular lesions. Now, having said that, let us move on to the next one. This is the Behcet syndrome. We're not discussing much about the Behcet syndrome. As you all are aware of that, it is a triad of symptoms, including recurrent oral ulcers with genital and ocular lesion. Highest incidence is around the Mediterranean place of Turkey and also in Japan. It is also a leading cause of blindness in young males. So if you look at the symptoms of Behcet, you can see there is a specific scoring criteria to make it as Behcet's syndrome. You can see the areas of eyes. There is uveitis, vision loss, optic nerve inflammation, whereas in the mouth you find aphthous-like ulcers and aphthous-like ulcers in the genital area. Although it's a systemic vasculitis, a lot of other systemic manifestations are also seen. Example, papillopustular lesions on the skin and inflamed pain and arthritis. Here is where you have to consider differential diagnosis of Fapa syndrome as well as MAGIC syndrome, that is mouth and genital ulcers, including inflamed cartilage. Now, the oral features of Behcet syndrome include recurring oral ulcers and mild recurring or deep large scarring lesions similar to major aphthous, and appear anywhere on the oropharyngeal mucosa may occur more than 3 times a day, and that is also a criteria. So the diagnostic criteria for Behçet syndrome is recurrent oral ulceration in at least 3 times a year, in addition to any 2 of the following, that is recurrent genital ulceration, eye lesion, including uveitis or retinal vasculitis, and skin lesions such as erythema nodosum and papulopustular lesions. Then even the test, as you can see, it is clinically diagnosed like oral, genital, and ocular lesions. It is definitely Behçet syndrome, but there is also a test which is called POSITIVE, which is a pathogen test. It was asked as a short note in some of the exams previously. It is a main diagnostic test where a 20 gauge needle placed 5 millimeters in the skin of the forearm, and the test is positive if you find an indurated papule or a pustule greater than 2 millimeters in diameter within 48 hours. Other lab tests are to rule out lupus erythematosus and severe neutropenia. As we said, there's some sort of systemic vasculitis along with it. Management, it is an immunosuppressive agent along with a systemic steroid, that is azathioprine and prednisone, the Vislon, which reduces the oral as well as the genital involvement. Dapsone, colchicine, and thalidomide again have also been used. Infliximab, that monoclonal antibody, and etanercept have active against cytokine TNF-alpha. Next infective lesion or the ulcer we are discussing is acute necrotizing ulcerative gingivitis. It is also called trench mouth, Vincent's infection, acute ulceromembranous gingivitis. It involves fusospirotic gingivitis. It involves the free gingival margin, crest of the gingiva, and interdental papilla. Causative factor, the Fusobacterium and Borrelia vincenti. Trigger factors: stress, resilient illness, smoking, and immunosuppression. As you can see, the picture, you can see the craters on the interdental papilla. This is pathogen for it. And the symptoms: sudden onset with pain and tenderness, profuse salivation, and metallic taste of the saliva. There is typical fetid odor, which is unpleasant. There will be slight mobility and apparent extrusion of the teeth. Hyperemic gingiva and slightly punched out crater-like erosions in the interdental papilla. The treatment of NAC involves 3 stages. First phase will be the control of the bacteria, local debridement, antibiotics, amoxicillin, metronidazole, paracetamol for heresy, and 2% hydrogen peroxide mouthwash. In the phase 2, following the phase 1, it is elimination of local and systemic predisposing factors, scaling and root planing to remove the local irritants, and periodontal surgery for the periodontal defects. And finally, the patient education about counseling about habits and proper oral care. Okay. And Anat was also asked, necrotizing ulcerative gingivitis was also asked in one of the short notes in some papers. Then moving on to those single ulcers, obviously you can find some source of trauma. Traumatic ulceration, they are evident from clinical examination as well as from your history. Identification of the trauma responsible. They resolve spontaneously and once the causative factors have been identified or removed. Mechanical trauma from sharp margins of teeth or a prosthesis, denture flange, self-biting, or factitious injury. Like, for example, some people have psychological issues. They try to bite, chew their mucosa itself. Sometimes they have self-mutilation habits like seen in Lish-Nyhan syndrome. And some traumatic ulcers result of thermal injury and chemical burns, iatrogenic and radiation-induced. Thermal injury, like for example, some children can bite into electrical wires and get ulceration. Sometimes, very commonly, you can see some ulcers happening on the palate as a result of food immediately consumed, taken out of microwave oven. Chemical burns, like for example, it can happen due to any caustic substances, whether it is poison ingestion or things like that, and sometimes with the procedures in the dental, like root canal, irrigants, or sodium hypochlorite accident. Sometimes it can be also iatrogenic, like for example, medication-induced. And there is also radiation-induced ulcers. Now, let us look at some of the traumatic ulcers, how they look at. We can see that on the more commonly, which is encountered in your clinic, is a sharp tooth related traumatic ulcer on the tongue. And the pizza burn, which happens on the palate, it can happen on any surface, especially in the palate region. Then you can see self-inflicted wounds on the tongue as well as buccal mucosa. Drug-induced cytotoxic drugs, methotrexate, doxorubicin, antithyroid, hydroxyureas, bone physiology drugs like alendronate, calcium channel blockers, and some NSAIDs, aspirin, ciprofloxacin, all these preparation can also affect ulcerations in the oral cavity. For example, this medication was used for arrhythmia, and the patient developed like this diffuse ulcer, exposing the underneath connective tissue. And on the right side, you can see aspirin burns on the buccal mucosa and vestibule, and some people place aspirin inside. Then certain food condiments and flavoring agents can produce, especially spearmint, cinnamon flavored chewing gums, toothpaste containing sodium lauryl sulfate, and also some pastries can trigger this sort of ulcers. Radiation-induced mucositis, I think, have been explained in your previous session on biological effects of radiation. Then, as you know, this chronic traumatic ulcer is one which needs to be dealt with cautiously because it has the potential to form malignancy. Most of the time, chronic traumatic ulcers turn into malignant ulcers, and it is one of the avoidable causes for oral cancers. Now, another form of ulcerations which you find in the oral cavity as a result of infective one is syphilis. So syphilis, there are a wide range of oral manifestations depending upon the stage. You know, the causative organism is Treponema pallidum. Several times this question, short notes, have been asked in your Manipal University exams. And the disease is divided into primary syphilis, secondary syphilis, and tertiary syphilis. Most of the lesions are seen around the secondary syphilis, which happens 2 to 12 weeks after the first contact, whereas chancre, which is a painless or painful, rarely gets noticed sometimes by the patients. And most of the time when the patient present at the secondary stage, don't recollect having a known chancre prior. Okay, so primary stage is highly infectious and they heal within 8 weeks without a scar. So just take a look at what all the lesions are. In first, primary is chancre. Secondary, we have a plethora of lesions, mucosal patches, otherwise known as snail tag ulcers, ulcerations like aphthis, leukoplakia-like patches, you call it as glossitis also, maculopapular lesions on the skin, and pseudomembranous lesion, and condyloma lata. Tertiary syphilis, gamma, atrophic glossitis, and syphilitic leukoplakia. Now, let us look at some lesions which are seen on the secondary stage, that is a syphilis mucous patches. You can see the snail track kind of ulcers on the corner of the mouth and on the lower labial mucosa, and you can see some maculopapular rash on the soles of the feet. The last one, the gamma or the tertiary lesion, you can see it on the tongue, and the tongue is also exhibiting features of leukoplakia, syphilitic leukoplakia, as well as lytic glossitis, or syphilitic glossitis. The key microscopic features of this is infiltration and proliferative endarteritis, at least in primary and secondary disease. And the causative organism may be demonstrated in some lesion by use of silver stain. Serological test. These are non-treponema, like Venereal Disease Research Laboratory for screening, okay, and treponemal test, which is for diagnostic confirmation, that is FDA and BS, fluorescent treponemal antibody absorption test. Treatment, early syphilis within 1 year can be treated with a single dose of intramuscular penicillin G, whereas a late syphilis, which is more than 1 year duration, requires a weekly intramuscular penicillin for 3 consecutive weeks. Neurosyphilis, penicillin for 10 to 14 days IV. Now, another infective ulcer is, apart from the syphilitic ulcer, is your tuberculous ulcer. Although only 3% of the patients with active TB develop this oral ulcer, gingiva, palate, floor of the mouth, lips, buccal mucosa, anywhere can be affected. And patients with these present with an undermining edge, we have seen an undermining edge. Mostly the tuberculous ulcers are represented by having a floor which is looking like a granulating floor or an apple jelly type appearance. But in oral cavity, this can take varying forms, but definitely there is some sort of undermining edges. And Mycobacterium tuberculosis, as you know, it is an airborne particle from infected person. It forms Cohn's complex in lung alveoli, where it remains dormant for several decades, and finally it gets into activation at the time where it is reactivated. What is important here is about how you deal with the patient with tuberculous ulcer. One is the present status, and also whenever you are taking, you must take more care while doing this aerosol procedures. It's better to consult an infectious diseases specialist, knowing the infectivity of the patient before doing procedures. Also, the area should be well ventilated with HEPA filters, and the patient be having that N95 masks whenever they are waiting in the lobby. And treatment is ideal when there is a negative pressure in the place of operatory. So these are the considerations where you have to look into while treating a patient with a tubercular ulcer. Then we cannot complete this without mentioning the vesiculobullous lesions that has been discussed in the last class. So in your vesiculobullous, that is one of the entities is herpes simplex infection, which forms primary infection by HSV1 and HSV2, represented by above waist and below waist earlier. And the primary infection is always in the mucosa or in the skin, and where they remain latent in the sensory ganglia. Sometimes extraganglional areas also seen around the lips, where on reactivation they form lesions. So you can see the primary herpetic gingiostomatitis affecting entire oral cavity, and look at the different ulcers happening inside the mouth, and also inoculation site at the fingertips, which is called primary herpetic Whittler. Note that the reactivation of the lesions happens on the outside the mouth, especially on the vermilion border. Second one is your varicella zoster infection. Varicella zoster, the primary lesion is what you call the chicken pox. So we are talking about one thing that is happening at a later date. That is just like your HSV residing in your cervical ganglion. This one resides in your cranial or spinal nerve ganglia, and on reactivation, it causes herpes zoster. So that the second is called your herpes zoster infection, and usually it is along the nerve that supplies a particular dermatome. And in early ways, it is called shingles or herpes zoster. In that picture, just adjacent to it, you can see that lesions are on one half of the palate, rarely cross the midline. And the complication of herpes zoster infections are post-herpetic neuralgia, secondary bacterial infection, paralysis, and meningoencephalitis, Ramsay-Hunt syndrome, and infection of this herpes zoster of geniculate ganglia results in Bell's palsy, unilateral vesicles of external ear, and vesicles of oral mucosa. Then another group of virus which is commonly seen is the Coxsackie group, especially among those who stays together in communal groups and closely knit families. Coxsackie group A virus 1, 6, 8, 10, 16, and 22. It occurs through ingestion, direct contact, or droplet spread. Commonly affects in children, occasionally older children and adults. And there is some difference when you compare simplex virus and herpes angina. You can see it occurs in epidemics, whereas herpes simplex does not have any connection, not necessarily having connection like epidemics. And herpes angina have milder course of the lesions and smaller lesion, whereas HSV is more severe. Lesions occur more commonly in the pharynx and posterior part of the oral mucosa in case of herpangina, whereas you have seen the pictures where this herpes simplex happens to be around the anterior portion of the mouth. And also, they don't cause much of a generalized gingivitis, and whereas acute marginal gingivitis is characteristic of HSV infections. And also lab findings, there are ballooning degeneration and multinucleated giant cells and intranuclear inclusion bodies, which are present in HSV, whereas all these features are not found in herpangina. You can see the posterior aspect of the oral cavity affected in case of herpangina. Now, another one is your cytomegalovirus infection, which is like an infectious mononucleosis type, pharyngitis, fever in a healthy immunocompetent individual requiring no specific therapy. There are palatal petechiae and submandibular lymphadenopathy. These are diagnosed via antibody testing, PCR, and histopathology. Management is ganciclovir and ganciclovir. And I think this is the end of my session. Over on to you, ma'am.
Yeah, thank you so much, Dr. Nishant.
Thank you, ma'am.
Ma'am, Deepa ma'am, is there anything to be added? Deepa ma'am?
Yes.
Is there anything to be added, ma'am?
No. Any
Okay, shall we
questions from?
proceed? Yeah, shall we proceed with the?
Yeah,
Shall
there
we?
are no questions. We can proceed to the next one. Can you display
Yeah.
the certificate, Uttara?
Yes, ma'am. Yes, ma'am.
Could you please stop the screen sharing, Dr.
Yeah. Dr. Nishant?
Yes, ma'am.
Could you please stop the screen sharing? I'm not able to share the certificate.
Can you get my screen now? I have stopped the share.
Yeah. So thank you so much, Dr. Nishant, for your insightful lecture on the topic ulcerative lesions. I guess our students are now into the topic and they have got a very good review on, a rapid review on the session, on the topic. So I think we can proceed with the next. And if you have any queries, please put in the chat box so that we can discuss the queries at the end of the session. Is that okay, sir? Can you wait till the end of the session for the discussion of the questions?
Sure, ma'am.
Okay, sir. Thank you, sir. And next, our topic of discussion will be preparation for the practical session, practical examination. The topic will be dealt by Dr. Beena Verma, ma'am. I think we don't need any introduction about ma'am because she is known to everybody. And for having a brief introduction, let me tell you that she is currently serving Amrita as a professor. And she's done her BDS from Rajas and MDS from Yenapoya. Over to you, ma'am. Please proceed with the session of preparation of practical examinations.
Okay, good evening, one and all. Can I share? Uttara, can you please stop sharing your screen? Yeah, okay. Okay, ma'am. Good evening, ma'am.
Good evening, ma'am.
Good evening. Are you able to see my?
No, ma'am. Yeah. Now we can see you, but the sharing is not.
No. Share. Where do I share? Share screen. Okay. Has it come now?
Yes, ma'am. You can proceed, ma'am.
So my slideshow is missing. Can you make it into slideshow? Or is it? I'm not. What to do now? Is this view is okay?
Yes, ma'am. Please proceed, ma'am.
Okay. Thank you, Assisia College and ASMIC. Somebody's this thing is open. So echo is coming. Can everybody mute? Shall I start?
Yes, ma'am. Please.
No, I'm hearing my voice. If so,
Ma'am, all the participants are muted. Let me check once again.
okay. I'll start. Okay, good evening. So now you have your theory exam is over. Up to the practicals. First of all, come prepared. Neatly dressed, proper apron, proper instruments. Okay. So now you have greeted and seated the patient on the chair. The next thing is listen to the patient. He or she is telling you the diagnosis. This you have to take with a pinch of salt because always the patient will not be telling true things. So put a sieve when you're listening. Okay. So now you come to history taking. What is history? Casey. It's not moving. Sorry, I'm not able to. What to do? Ah. So we start with history taking. So first will be graphic. Before that, what is history taking? It is a planned professional conversation. So you may be thinking, who are the two professionals? One is yourself, and the other one is the patient, who is the professional in the problem he has. Okay, so it could the format that we use is a semi-structured one, which is flexible enough for you to include all the needed data. At the same time, it ensures that you include all the needed data. Okay. So the components are identifying data, all the demographic data, name, age, gender, etc. Then the most important part is the chief complaint and the history of presenting illness. So, and these are the other parts, history of presenting illness, medical, other histories. We'll concentrate on history of presenting illness. Okay, so you have to follow a systematic order. the format is chief complaint. The chief complaint should contain the complaint proper, the duration, and the location. So duration, because next what you're going to do is taking history of presenting illness. So how will you define the history? How much history you have to take? That the duration will tell you. If it is 7 days, then you will be taking the 7 days history. And only you will go back if it is needed. So the duration defines the history. Then the location. Why location is important is you have already decided where you are going to do the local examination. Okay. So the history of presenting illness definitely should include origin and onset. Onset is very, very, very important. Say, for example, if it is a swelling, how it started. It started all of a sudden or slowly. Or why this is important is if sudden onset swelling may be an inflammatory one, whereas the other one, slow onset swelling may be a tumor also. So this distinction, each step, each question that you ask the patient, in your mind, you're making and deleting, including deleting diagnosis. So you ask onset, how did it start? All of a sudden. So you remove all the slow onset swellings from your differential diagnosis. So similarly, duration. Acute conditions, you delete all the chronic conditions. But sometimes it may come and go, progression. So in such cases, it could be an inflammatory condition which comes, say for example, an abscess, which comes, makes a sinus opening, reduces, later it comes back. So each step, each question is a clue. And the aggravating and relieving factors. Say, for example, you have the dental pain. So what is the aggravating factor? Is it chewing, or does the chewing reduce it a little bit? This makes a lot of difference. If it is increasing, it may be a periapical lesion. If it reduces, maybe it is a periapical periodontal lesion also. Okay, then the associated signs and symptoms. Associated signs and symptoms depends on the complaint. If it is pain, it's a different set of associated signs. So pain with swelling, lymphadenopathy, etc. Definite 99% it may be an inflammatory lesion, but you cannot exclude carcinoma, but the duration and other characteristics will decide. Then radiation, whether it is radiating to other areas, any other previous treatment. Why previous treatment is important is, if the previous treatment did not work, you should not resort to same treatment. And previous investigations are important because either you may have to do a new investigation, or you may have to avoid further investigation, or you may compare the previous one with the new one. So that is why previous treatment and investigations are important. Then the medical history. 99% of the medical problems has one or other oral manifestation. So your problem, the problem with which the patient must have come to you, may be a sequelae of a medical problem also. Say, for example, uremic stomatitis, radiation, mucositis, etc., etc. Radiation caries. So the medical history is very important. Not only for that, for treatment also. A diabetic patient, a hypertensive patient, patient with epilepsy, a cardiac patient. So when you plan the treatment also, these medical histories are very, very, very important. So you have to record the medical history. And medicine, history of medicine, the medicine the patient is taking, the drug history. many 99% of the drugs cause xerostomia. So if the patient comes with a complaint of xerostomia, the first thing that you have to ask is the medical list, the medications that the patient is taking. And the medication that you are going to give to the patient should not interfere with the drugs the patient is already taking. So that is the reason why medicine history or drug history is also important. And personal history, habits, etc. The lesion that is present or the complaint that the patient is giving may be secondary to the habit history, especially tobacco habit, arecanut. Patient is not able to open the mouth. Maybe the patient is having submucous fibrosis. So medical history also. And when you're writing about the habit history, the habit index also is very, very important. So why index is important is indices are made for comparison. Say, for example, one patient smokes 10 cigarettes for 5 years. Another patient smokes 5 cigarettes for 4 years. So how will you compare who has the more propensity to develop any tobacco related lesion? So that is why habit index is important. Then the past dental history. So most of the time in the past dental history, most of the students write the same history of the presenting illness. It is not. Anything other than related to the presenting illness, that you should write in the past dental history. Then the family history. Many of the diseases have a genetic or familial tendency. So to rule out family history also is very, very important. On all these have to be recorded properly. Most of the time, half the thing will not be there. Because this is the only legal document. If anything goes wrong, this is the only thing that can help you. So unless and until you write it. And one more thing, when you're writing it, if you make a mistake, make a clean cut and sign it. Don't cut it. അത് ഒരിക്കലും വായിക്കാനേ പറ്റാത്ത പോലെ വെട്ടിക്കളയരുത്. Sorry, it is not moving. Okay. So then comes your examination. So in general examination, you have to follow the universal protocol. That is inspection or just observing, palpation or hands-on, percussion or tapping, and auscultation. Auscultation usually we do in the head and neck examination for TMJ examination. Okay. So general examination includes the gait, build, consciousness, cooperative or not. All these have some implication in your diagnosis and treatment plan. That is why you cannot miss any of these. Okay, so each one will need hours together to explain. So I'm just browsing through it. And this acronym, PICCLE, P-I-C-C-L-E, that will help you to remember what are the things that you have to look for when you're examining the, when you are doing the general examination. Pallor, icterus, pallor. So when these signs, you should know where to look for, what should you ask the patient to do, what you should do, what is a normal finding, and if there is a change, which system could be involved, and if that system is involved, what is the normal function of that system, and if that system is impaired, what is the general implication and what are the oral implications? Will it affect your oral diagnosis? Will it affect your medication? Will it affect if you want to do a surgery? So it is very important that you examine pallor, look for pallor, that is in the skin and mucosa. Especially, you retract the lower palpebral conjunctiva and see the color. If it is pale, you assume that pallor is positive. It may be a sign of anemia. So many systems may be involved, including liver and kidney. So these are very important organs as far as treatment is concerned. Then icterus. It's the sclera may be yellowish, indicating that there is a problem with the liver or the RBCs. Then cyanosis, again, a sign of systemic disease, cardiovascular, respiratory, clubbing, and lymphadenopathy. So regarding lymphadenopathy, generalized lymph and cervical lymphadenopathy are slightly different. You call lymphadenopathy in general examination only when there are more than 2 groups of lymph nodes are involved. That is cervical, occipital, inguinal, because generalized lymphadenopathy indicates a systemic condition, including even medication. In anti-epileptic medication, etc., can produce generalized lymphadenopathy. So, even tuberculosis, AIDS, etc. Then you look for edema. Edema could be perioral edema, periocular edema, or even anesthesia edema, which is a result of mainly kidney or mainly liver problems. Can you help me with? So non-pitting edema, this is how you check for pulse. These are all photographs. Sorry, there is a problem with my computer. Okay. Then extraoral examination. In extraoral examination, what all we check for is the symmetry of the face, the profile, the TMJ, the eyes, salivary glands, skin, ears, lips, vermilion border, angle of the mouth, etc. So we'll see one by one. So eyes, there could be so many different changes in the eyes. So red eyes, this is cataract patient. This is blue sclera. This is neurofibromatosis. So eyes also can be affected. Then symmetry. You have to see the vertical symmetry as well as the horizontal symmetry. So there may be so many reasons. When you're writing, you write no gross asymmetry detected because there is a certain asymmetry between the left and right side. So that is why you write it as gross asymmetry. Gross asymmetry indicates some pathology. It could be a swelling, it could be a hyperplasia, hypoplasia, etc., etc. So this patient has a swelling on the maxillary antrum region, which could be a maxillary antrum carcinoma, whereas this is a third molar swelling, which is related to space infection. So neatly this shows facial asymmetry. Then the profile. Profile is the lateral view. So straight profile is usually associated with class correlation, whereas convex profile with the class 2 and concave profile with class 1. Sorry, class 3. Then the examination of the lymph node. So when you are examining the lymph node, you ask the patient to turn to the same side. Why? Because we want the muscles to be relaxed. And how do you do the examination? You use 3 fingers. The middle finger is the one with which you examine, and the other 2 fingers are for stabilizing. Because lymph node examination, it is a soft tissue, it may slip. So it has to be palpated against some hard tissue. So the available hard tissue over there is the mandible. So you palpate it against the lower inner aspect of the lower border of the mandible, and always do it from anterior to posterior. Otherwise, many times you may not miss it. So the lymph node can tell you stories about the patient. Single node, multiple nodes, mobile nodes, fixed nodes, soft nodes, fibrous nodes, hard one. All these will tell you different stories. If it is rubbery in consistency, it may be a sign of lymphomas. If it is bony hard, it may be a sign of malignancies, etc. So never miss a lymph node. A few oblong, soft, tender lymph node may indicate 99% of the cases an inflammatory lymph. So definitely look for some lesion in the oral cavity. And palpable lymph node is always a sign of pathology. The thing is, the pathology may be a past pathology. Pathology must have removed, but the lymph node may remain. So this also has to be kept in mind. Then the examination of the TMJ. So TMJ examination can be done standing in front, standing behind. Preferably you stand in front. Because the first thing that you're going to look for is whether the patient can open the mouth or not. Place the finger in front of the tragus on both sides. Ask the patient to open the mouth. Look for whether the patient can open the mouth properly. If the patient is opening the mouth, whether there is tenderness, signs of tenderness. Don't ask the patient, is it tender or not? So the difference between pain and tenderness is, pain is a symptom, whereas tenderness is a sign which is elicited by the clinician. So when you start examining, don't write pain. When the patient complains, you can write complaints of pain. But when you're writing in the examination, write it as tenderness. Okay, so whether tenderness is present while opening, while closing, or both. Whether there is a deviation of the mandible to any side, each one will tell you a different condition of the TMJ. So the deviation of the mandible to one side may be because of a problem on the same side or the problem on the opposite side. This you have to differentiate. Which all conditions you will get deviation of the mandible to the same side, which all conditions you will get the mandibular deviation to the opposite side is very, very important in deciding what the problem is and where the problem is. And tenderness also. Is it while opening? You have a different set of muscles involved. Is it while closing? You have a different set of muscles involved. So this distinction also is very, very, very important. This is a short video which shows the opening and closing of the mandible. Sorry. Okay. So this is a normal opening. So the disc goes along with the condyle and comes back to normal. Okay. So see this one. In the first case, it goes along, gets stuck, but with a click, it comes back. So the deviates, comes back to normal with the click and closes. So this is disc displacement with reduction. Whereas in this case, the click is not there. So the deviation and closing are in the same path. It doesn't come back to normal. So close observation has to be there to diagnose problems of the TMJ. And for listening to crepitus, regarding TMJ, you have clicking, you have crepitus. Crepitus is a subtle sound which is not audible for the naked ear. So that is why you may have to use a sket. So this patient has a deviation, obvious deviation while opening the mouth. And the salivary glands, the lifting of the track, this portion of the ear definitely tells you there is a swelling of the parotid gland. So salivary glands have to be examined extraorally as well as intraorally. So the parotid gland you do with bidigital palpation, that is you use two fingers and you are looking not for the presence of salivary gland, you are looking for any abnormality. So when you start writing, don't write everything normal or you are looking for abnormalities. So you should write no abnormality detected, or whatever abnormality you have detected, you write that. Because there is nothing normal. Everybody's shape, size, everything is different. So which one will you consider as normal? That's why you are looking for abnormalities and you'll be writing no abnormality detected. Okay, so salivary glands, as far as parotid is concerned, bidigital palpation is needed, looking for the change in consistency, tenderness, any hard, etc. And intraorally, when you are examining, you have to milk the saliva and see whether the salivary fluid saliva like hard and it's not moving. I'm very sorry. There is a problem. Okay, so now you go for intraoral examination. So when you're doing the intraoral examination, you have to have an adequate light source, uh, mirrors, gloves, tongue blades, gauze pads, etc., etc. So you follow a systematic order. Otherwise, you're going to miss so many things. Okay. So follow a clockwise section: labial mucosa, buccal mucosa, gingiva, tongue, floor of the mouth, palate, facial pillars, and oropharynx. So labial mucosa, you have to, I'll show you the pictures, that will be better. So the lower labial mucosa as well as the upper labial mucosa with your gloved hands and check for change in color, change in size, change in consistency, any swellings, any redness, etc., etc., and the frenal attachment also. Same way you have to go for the upper lip also. A mucocele-like swelling, which is seen in the lower lip, may be a mucocele, whereas the chances of it becoming a mucoepidermal carcinoma in the upper lip is more. Why? Because lower mucosa has there is every chance that it get traumatized, because there may be habits, there may be a procline tooth, etc. But in the upper, the chances of getting traumatized is very, very, very less. Then the buccal mucosa. So what you have to remember is, when you examine the buccal mucosa, you keep your mouth mirror in the corner of the mouth or the retrocommissure area. Most of the time, you miss out any lesion present in that area. So what you have to do is, first you examine the retrocommissure area, then retract. And remember, there are so many normal variants present. So normal variants are not normal, but doesn't warrant a treatment. Like your linea alba, Fordyce's granules, and sometimes the parotid papillae may be so large, you may mistake it for a kept in mind when you're examining the buccal. These are the common variants. No, this is a question. Somebody want to answer? Otherwise, I'll skip. So this is the Stenson's duct opening. And leukedema. So how do you differentiate leukedema from other white lesions? You stretch. Because it is edema, the fluid may dissipate, so the color may come back. And when you release, it becomes pale again because of the collection of the fluid. Then you examine the retromolar pad area properly for any variations or any change. Then the fascial pillars also. Fascial pillars are anterior portion of the fascial pillar is the palatoglossus muscle. Posterior part of the fascial pillar is the palatopharyngeus muscle, and in between you have the tonsillar fossa. So look all these areas properly. Then you go to palate. First you examine the soft palate, then the palate, hard palate. So you have to remember that there are so many normal things like the rugae, the glandular zone, the mid-palatine raphe, the fovea palatina, etc. So look for all these, and this picture shows a dental abscess, which is not normal. You may find a swelling in the middle of the palate, which may be a torus palatinus. And check for the uvula, the soft palate, whether the mobility is proper or not. Depress the tongue and see the throat also. And always remember, you are looking for abnormalities. So these are all various abnormalities that may be found. And this is denture stomatitis due to this denture. Then the floor of the mouth. Examination of the floor of the mouth, bimanual palpation of the salivary glands, and tongue should be raised. And anterior floor of the mouth, look for the frenal attachment, the openings of the salivary glands, etc. And in elderly patients, where the posterior teeth are lost, the floor of the mouth may look like a swelling, and you may mistake it for a mass. So these are various lesions that may be present in the floor of the mouth. Then the tongue. So with the patient's tongue at rest, the mouth partly open and inspect the dorsum of the tongue for any swelling, ulceration, coating, or most of the patients may have coating. So these coatings, if they don't remove it, patient may have chronic pharyngitis. The color, the texture, whether there is depapillation present or not, any abnormality of positioning, that is the anterior positioning, the tongue frenum, etc. So what is a telltale sign of ankylosing is when the patient tries to put the tongue out, there will be a V-shaped notch in the anterior tip of the tongue. This is a classic sign of ankylosing. This is the depapillated tongue. And in elderly people, when these papillae may be so enlarged and they may be traumatized, the circumvallate papillae, it may look like some lesion. Ulcer present on the dorsum of the tongue. Mainly tuberculous ulcer is present on the dorsum of the tongue because when the patient spits the sputum, it may get lodged in the dorsum. So this is a tuberculous ulcer present on the tongue. This is the enlarged tongue. So the crenations on the lateral borders of the tongue may indicate an enlarged tongue or a lingually placed tooth or an iatrogenic problem where the complete denture prosthesis, the teeth are not arranged in the neutral zone. So these are various variations that you may find. This is a carcinoma, this is a fungal infection, etc. The ventral surface of the tongue. The veins of the ventral surface on the tongue may be so enlarged in elderly, it may look like a lesion. So this is an aphthous ulcer present. These are all veins present on the dorsal surface. So then you gingiva. You may find a retrocuspid papilla. So when you're examining the gingiva, the thing that you look for are the color, the contour, the position, the consistency, the surface structure, texture, whether bleeding on probing is present, pockets are present, etc., etc. So stippling. Stippling is present mostly in the anterior region in young adults. So it starts at the age of 5 to 6 years when the permanent tooth start erupting. So if you want to see stippling, you have to dry the gingiva and see, because even a certain amount of saliva can obscure the pits. Sorry. Then you have fibrous nodules at the mucogingival junction. These are all normal variants. You need not worry about it. They don't warrant any treatment. You may have a retrocuspid papilla. So these are all various pictures. And there is physiologic pigmentation. Even though Karanza says gingiva is coral pink, in the Indian situation, if you have coral pink gingiva, it is a sign of gingivitis. So the physiologic pigmentation will be coronal to the attached gingiva. So when it extends beyond, then it may be pathology, as in case of smoker's melanosis. So this is checking for bleeding on probing. The instrument has to be held parallel to the tooth surface and apply only pressure enough to blanch your fingernail, not more than that. Because the instrument is very sharp, and if you apply more pressure, it may penetrate and start bleeding. So periodontal probe, how it is being used for searching pocket. It has to be inserted between the buccal surface of the tooth, all surfaces of the tooth, between the tooth and the gingiva. And the pressure applied should be just to blanch 25 grams, that is just to blanch your fingernail. So this is how it is being done. So these are all signs of severe periodontitis. Then you go to hard tissue examination. So you have to write the type of dentition, the number of teeth present, the type of occlusion, any change in the occlusal pattern like rotation, transposition, everything has to be included in your case history. Any missing tooth, any change in size, shape, restorations, caries tooth, fractures, artificial dentures, attrition, abrasion, mobility, supraocclusion, infraocclusion, everything. So these are all various anomalies. This is an mesiodent, talens cusp, paramolar. So various lesions. There is a twinning or gemination that you decide by counting the number of teeth or by taking a radiogram. Then you write about the occlusion. So when you're writing about occlusion, don't write class 1 occlusion, class 2 occlusion. It is class 1 molar relation, class 2 molar relation, class 3 molar relation. Occlusion is the malocclusion or it's a diagnosis. So it is a molar relation that you're writing. Or you may have to write the canine relation. So this is the canine relation, class 1, class 2, and class 3. And even the anterior relation, whether overjet and overbite is proper or not. Many of the lesions may be, especially in the lower anterior gingival recession, etc., may be due to the anterior relation. See, these are all various anomalies which you need to write, because most of the time these things you miss. You concentrate on your clinical, the patient's complaint, and only those findings related to that you write. But all other, the patient has come for examination. It is your duty to detect each and every problem. I'll go fast. Do I have the time? I'll continue.
Yes, ma'am. Yes, ma'am. Continue.
Okay. So now you check for furcation involvement. So what is furcation involvement? The furcation is getting exposed to the oral cavity. It doesn't mean that it may be clinically visible. So the furcation 1 is you get a catch in the furcation area. Still, with naked eyes, you can, unless you retract the gingiva, you may not be able to see it. Then the second is cul-de-sac. That means your instrument will go to one side. It may not come out through the other side. And class 3 is, it will go through and through. But in all these 3 cases, it may not be clinically visible unless you retract the gingiva. The class 4 is clinically visible furcation, as in this case. So this is the radiographic finding. Then the mobility. It is Miller's classification is used, class 1, class 2, class 3, or grade 1, grade 2, grade 3. Grade 1 is in a single direction, grade 2 in 2 directions, and grade 3 even compressibility also will be there. So it may indicate periodontal disease, a cyst or a neoplasm or abscess, occlusal trauma, crown fracture, fracture of supporting bone, etc., etc. And how you check for mobilities, you can use the 2 instruments or your 1 finger and 1 instrument. Then you look for discoloration. There may be umpteen reasons why tooth can get discolored. It may be a single tooth discolored, which you diagnose as most of the time as traumatic problem, or it may be yellow, brown. It may be less translucent. As you age, the translucency of the enamel reduces, the dead tracts appear, sclerotic dentine, and the color may change. When the pulp dies, it may become gray, black. Fluorosis, it may be white, yellow, brown. So all these history also will tell you the diagnosis. Then internal resorption, which again may be a problem secondary to trauma. So this indicates some medical problem where tetracycline stains. So it is a line at what time the patient must have taken the medication. It will indicate. Then detection of caries. Mostly 90% of the patients come because of caries. So detecting caries is very, very, very important. So you can do the inspection, you can do transillumination, you can use disclosing solutions, you can use flossing, and most importantly, what you do is probing. And this probing again, when you do, don't apply much pressure, just enough to blanch your fingernail. And you have to have enough light. So when you're viewing the upper arch, always use light from the front. And when you're viewing the lower arch, always keep the light above. And 28 inches away. You don't want to do a photodynamic therapy and heat the patient, right? So there should be sufficient distance. And upper arch, when you are examining, the mouth mirror has to be kept slightly outward so that the breath will not fog the mouth mirror and it will reflect the light. So it serves 2 purposes. So these are various teeth must be clean and dry. So when the caries is detectable, when it is dry only, you don't have to treat it because even the saliva will take care of it. Remineralization may take place. But when the caries lesion is visible, when it is wet also, that means it has progressed and you may have to. So this is a classification which I know you are well versed with. So these are all various types of caries, opacity, discoloration, tissues of this. This is root caries. The root is definitely exposed to the oral cavity. Keep all these. You may use Diagnodent handpiece for transillumination also. trauma. So, I'm very sorry. Then you may have to go for chair-side investigations like percussion test, pulp testing, diascopy, etc. Diascopy especially to rule out hemangioma, etc. So once you finish the examination, you have to do a local examination. Local examination depends on the lesion that is present. So this has to be done under inspection and palpation. And in the case of tooth, you may have to do a percussion test also. So first I will explain only in relation to a tooth because otherwise it will take too much time. So first inspect the gingiva around the tooth, inspect the vestibule and inspect the tooth. Then you palpate. Palpate the gingiva, palpate the vestibule, check for bleeding on probing periodontal pocket, etc. And then you palpate the tooth or probe the tooth to see where the margin of the cavity rests and check for mobility, etc. Then if indicated, that is if the vestibular palpation is positive for tenderness, then you do a percussion test to confirm. Okay, this is how a tooth is examined. A lesion examination is slightly different. Most of the time, you will be coming across tooth problems. That's why I'm concentrating on that. So once all these are over, you may have to write a case summary. So this case summary should include the demographic data, the complaint, and the positive findings. So a -year-old patient presenting with what are the complaints with the duration, habit, examination, what have you find, and the case summary, it should be as brief as possible. And it should end with, based on history and clinical findings, the provisional diagnosis. And always, you may have multiple diagnoses, but always a diagnosis pertaining to the complaint should be written first. Then you go for investigations. Different types of investigation as the case may be. Most of the time, you advise radiograph, that too periapical radiograph. So this is how the patient should be positioned when you're taking the radiograph. The occlusal plane parallel to the floor. For the maxillary, to make it parallel, the patient's head has to be slightly bent down, whereas the mandibular, the chin has to be raised up. So the horizontal angulations also has to be taken into consideration. Most of the time you miss it. That is why you get cone cuts. So these are the various horizontal angulation and the points to remember. And now you have got all the investigation reports also. So points to remember is, do not, and in case of radiographs, do not trust what you think you see. Most of the time, you don't see what you don't know. Okay, so assess critically, be aware of and avoid common perception problems, confirm findings with other projections if needed. If periapical radiograph is not enough, go for an occlusal radiograph. And use contrast material and or other techniques to increase certainty if necessary. So this is how you write the report. There is a lesion over here, intraoral periapical radiograph of left maxillary posterior region. The landmarks that are present, the teeth are present, the tooth of interest. Then the radiographic finding, there is a uniform coronal radio opacity involving 3/4 of crown with a well-defined radiolucency of less than 1 centimeter. So the dimension also is important. The sclerotic border, that is also important. Other findings are also, you write, then the diagnosis will be pertaining to this radiographic finding. It is a periapical granuloma. Then you have localized periodontitis in addition to this. So you have a final diagnosis. Based on these investigation reports, you come to a final diagnosis. And the final diagnosis decides the treatment plan. And the treatment plan also depends on the age of the patient, the demand of the patient also. Even the financial matters also should be taken into consideration, but you write a treatment plan. As far exam is concerned, you write what treatment is absolutely needed. You make a formal treatment plan. So it could be just counseling or a medical treatment, surgical treatment, physiotherapy, psychotherapy, whatever. You have to give instructions to the patient, and essentially you have to write a prescription. And when you're writing this prescription, few things have to be remembered. Patient's age, date, all these things. And every medication should be written in 2 lines. The first line is whether it is a capsule or tablet, etc., name of the medication and the duration, the number. This is for the pharmacist. The second line is for the instruction for the patient. How many times and how it has to be taken, whether twice a day, whether thrice a day, or before food, after food. All these instructions should come in the second line. So if you are having 3 medications, there should be 6 lines with your signature. So then you have the prognosis. So what is prognosis? When you do a treatment, you have an expectation. Is it going to work or not? So that is prognosis, the prediction of the probable course and outcome. So now this ends with your clinical. We'll run through your Viva also. 2-3 slides only. So when you're coming for Viva, be confident. Do not panic. Then the whole thing will go. Speak with structure. Haphazardly don't talk. Use professional language. And make definitions definite. Definitions are ideas given in definite terms. So you cannot change the words. So definition has to be definite. And give short and crisp answers. Don't beat around the bush. Okay. Mention safety concerns when you're prescribing medications, and do not jump to treatment. So if you're asked, a patient is having squamous cell carcinoma, how will you treat? Don't jump into conclusion. It depends on the stage of the disease. It depends on the availability of treatment, the physical condition of the patient. So don't jump to that radiotherapy or chemotherapy. Don't do that. Do answer in a systematic manner. So squamous cell carcinoma has to be treated depending on the stage of the disease, depending on the site of the disease, the age of the patient, the physical condition of the patient, the availability of the treatment, etc., etc. That will give a better chance to get better marks. Okay. So what examiner look for is whether you can critically think your communication, how, because the examiner and you have to be in the same premise, talking the same language. There is a fun statement. Doctor is telling the patient, your diabetes has come from your father's genes. And the patient is telling, I never wore my father's jeans, so how can I get it? So it should not happen that way. And you have to have the mastery of the subject, or at least you should show that you have. You have the confidence, you should be clear, and you have to have critical thinking and analytical reasoning has to be there when you're answering the question. So things to do and avoid. So you listen carefully to the questions. It's okay to ask for clarification. Nobody will, if you're not sure what was asked, you can ask. Take a moment to organize. Don't jump into the answer. Listen to the question, take a moment to organize your thoughts, and then answer. If you don't know something, be honest. Don't beat around the bush and dig your own grave. You go laterally, the question also will go that way. So show enthusiasm for your work, and your body language is very, very, very important. Be confident. So try to avoid going off the tangent. It's like മലയാളത്തിൽ ഒരു ഇതുണ്ട്, പശുവിനെ പിടിച്ച് തെങ്ങിൽ കെട്ടി തെങ്ങിനെ പറ്റി ചോദിച്ചാൽ തെങ്ങിൽ കെട്ടിയ പശുവിനെ പറ്റി പറയുന്നത്. Okay, so overly long answers you should avoid. And the most crime that we can make is being unprepared for the practical questions. So this is in a nutshell. There is, I don't know whether I have crossed the limit. Lots and lots have to be discussed, but within this time, I could prepare only this much. So all the best for all the students. If you have any doubts, you are free to ask.
Thank you so much, ma'am. That was really a nice class on practical examination preparation. And I guess all our students will be recollecting your words during their practical examinations. Thank you so much, ma'am. And I think this was the last session of our rapid review session. So before we wind up, ma'am, can you please stop sharing your PowerPoint?
Oh, okay. So if you have any doubts, you can ask or you can contact me. I have no issues. Anytime you can contact. I'm always happy to share my.
Yeah, so I think any student, anybody who is having any queries, as I said earlier, can either directly ask questions, or if you have any shyness in asking directly, you can also chat, type it in the chat box. We are ready to answer all your questions. Both our speakers are here. So the topic 1 and topic 2 both will be dealt for another few more minutes. If you need any queries, if you want any queries to be answered, please feel free to ask. And this was the last session. So I think if you have if the previous sessions also, if you have any doubts, I think you can come up with the questions because this will be your last day. And next, you are going in for your examinations. So please feel free. Any topics dealt in the past few days, you can feel very free to communicate and get your answers to the queries.
ഒന്നുമില്ല, ചോദിക്കാനൊന്നുമില്ല. രാത്രി ഇത്ര നേരമായി വിശന്ന് തുടങ്ങി.
അതെ, എല്ലാവരും എല്ലാം മനസ്സിലാക്കി എന്ന് വിചാരിക്കാം മാം. എല്ലാവരും എക്സാമിന് അടിപൊളിയായിട്ട് പ്രിപ്പയർ ചെയ്ത് ഈ ക്ലാസ് ഒക്കെ യൂസ്ഫുൾ ആക്കി എക്സാമിന് വരുമെന്ന് നമ്മൾ വിശ്വസിച്ചുകൊണ്ട് I think it's
All the best,
ma'am, Deepa ma'am.
everybody, and thank you.
Deepa ma'am, are
Okay.
you there? Yeah.
Yeah. Okay, thank you, Beena ma'am. Thank you, Uttara. And thank you, my
Yeah,
dear
thank
students, for attending these 21 online sessions. And I think we have covered nearly 95% of the most important topics. So all the best, prepare well, and face your exams with confidence. God bless you all. Thank you.
Thank you.
And as I told, any doubts, any clarification, I am always free.
One more announcement. All the PPTs are and all the PPTs and question bank will be shared in the respective groups. And our YouTube live streaming will be there for 2 more days. 18th. It will be all the videos will be available on our YouTube channel till 18th 5 p.m. So please watch it before that, and beyond that it won't be available. And please don't ask in person for all the study materials. So you have 2 more days. You can watch it if you missed any of the sessions before. So it will be available till 18th 5 p.m. Okay, thank you.
Okay.
Thank you.
Thank you all, and good night.
Good night, ma'am. Good night, Deepa ma'am.
Good night,
Thank you,
Uttara.
Tara.
Good night,
Thank
ma'am.
you, Deepa.
Okay, ma'am.
learning